Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD podcast. It's dangerous today, Tro. We have someone who might analyze us or something.
Oh, geez. What he'll find out, I don't know. I got to be honest with you. It's like Pandora's box. Once he starts, we may be here for a lot. We're going to end up paying him,
Yeah. This could be like a free session, maybe. Who knows?
Listen, I'm excited because the topic of bariatric psychology is very important. And I actually met our guest today, not too long ago, at a conference where he spoke, and we were both speaking together. And we met each other a couple of months before that, doing some interviews and exchanging some ideas. So today we have Dr. Stephen Reyes. He's got a doctorate in education, and he is a bariatric psychologist. He's been in this field since 2005. He's helped thousands of people who are either looking to lose weight, keep weight off, or going into bariatric surgery. And I'll tell you, he was one of the people I really enjoyed meeting at this conference we did in Newport Beach, and what an amazing community it was of people who are, looking for support, looking for help, looking for compassion, and so I am excited about this. I'm excited to learn more about bariatric psychology, about what it takes to keep weight off. And I'm excited to trash talk the APA a little bit. So we'll see if we can get that in there. I'm just excited. Thanks for coming, Dr. Steve.
Yeah, thanks for having me for sure. Yeah, I appreciate it. Yeah, and right back at you. I was fortunate to interview all the speakers at the conference, and it was no secret to my wife, like you were my favorite of the group or whatever. I was excited after I met you, and I think we kind of felt like I had a kindred spirit out there, which was really cool. And then meeting you in person at the conference, that was very cool. Good
Yeah, listen, I absolutely had a great time there, and I felt the same way. I think the more we look at obesity as not only a metabolic issue, but as a issue that requires psychological support and requires help with mental health, I think the better we will do. And so I'm excited to hear everything you got. And maybe you could start with just how you came to this space, how you came to advocating for patients with obesity. How did you get there?
Yeah. So, going all the way back to 2005, there weren't a whole lot of, people specializing in bariatric psychology in those days. And I had been working in addiction for quite a while. I'd run a dual diagnosis program as a director of that for a bit. And one of the hospitals, well, a couple of hospitals where I'm from, approached me about working with the bariatric population. What they were looking for was they needed to do psychological clearance before they could proceed with surgery. So they're like, "Hey, Steve, would you be interested in this whole thing?" And I didn't know a whole lot about it. I knew maybe a couple of people had, weight loss surgery, but beyond that, I really didn't know a whole lot about it. And asking around my colleagues and stuff, no one else really knew a whole lot about it. So me, just who I am personality-wise, I'm open to a lot of things. I love newness. I love learning or whatever. I'm like, okay, well, let's check this out. And gosh, to make this really short, it just fit, man. Like hand in glove, like who I am as a person, what I'm about, my philosophy of life and everything. It just totally, fit with the bariatric population. So I started doing psychological clearances at that point. And, fast forward 20 years later, 15,000 people later, here we are. And it's just crazy how, for me, it's definitely a God thing because I wasn't seeking it out. It sought me out. It found me. And it's just been the coolest thing ever, my career, personally and professionally,
What were the biggest surprises for you when you started counseling people that, when you're doing the mental assessment on people who are about to get bariatric surgery? Were there any common denominators, some early childhood trauma, or any things that you saw that or a people pleaser, whatever it may be? What traits did you see that were kind of common in the patients that you were evaluating?
Yeah, great questions. So from a behavioral standpoint, and this is something I've been tracking my entire career. I'm a big tracker guy. Like I've always tracked, my doctoral background, I'm a phenomenological researcher, so I love details. Details are really important to me. And so I track a lot of things. I track themes, different, common behaviorals with people or whatever. And right out of the gate, it was so interesting to me how by far the majority of the patients, and I'll ask my friends and colleagues this because I geek out on this stuff. What do they think is the most common behavior that bariatric patients struggle with? And people say, well, obviously overeating and all that. The biggest thing by far is skipping meals. And it's not even close of all the things. Like my running track or my running percentage right now, I think is 76.2% of the bariatric population I've worked with over the years have a history of skipping meals, especially breakfast. That's not even close. Number two is eating a combination of home prepared and takeout or fast food. That's number two with that population. But later, as I got into it, the profile, psychological profile, if you will, as I went along, is that kind of developed. And as I finally kind of understood, the population I was working with, they tend to be really, really good at taking care of others, not so much themselves. And so I categorize that as like self-neglect. And so as you guys know, any of us, when we're on a health journey, once we make that commitment, putting myself first, taking care of myself, and my health as a priority for a lot of the people I work with and the bell curve of them, that tends to be the most counterintuitive, unnatural thing for them to do is to do that very thing, to establish themselves as a priority. And as, awkward as that might be to establish that, it's a whole nother thing to maintain it because the systems that they're a part of is going to work against them to push them back into the prior version of who they used to be once they do establish that.
I think it's I got to be honest with you. This is I think really hard for people to understand. They come probably both to you and to me and to Brian and saying, "Hey, I want to lose weight. Like, what do I need to eat?"
Mm-hmm.
And all of a sudden you're like, "Hey, let's pump the brakes on that and let's sort of think about the mindset and what it's going to take to not only lose weight but keep it off." And I'll give an example. Just yesterday, I had a patient who said to me, "Tro, me and my husband are in this together. They're so appreciative of, what we're doing for them and the app and what they're getting from us." And she said, "You want to know what the hardest thing is?" She said that, we decided we're not going to make food a thing. And they said all the date nights, all the celebrations, all like, we're not going to make food a thing. And she was like, this is harder than any diet.
Yeah.
They're doing this one thing, which is not to make socializing about food, was harder for them than any aspect of dieting.
Yeah.
Right. And so I think it, brought into mind exactly what you're talking about that, hey, wait a second, there's more to weight loss than just nutrition. It's actually deeply part of our human experience.
Oh, absolutely. Well, and yeah, and and you guys have heard this before, and this tends to be a popular thing within the weight loss surgery community. Those on the outside, often look at it as it being the easy way out. And I've had people, say that to me over the years too. And I'm like, okay, think about this though. So, you've been practicing a certain behavior for 40 years, 30 years, whatever it is. Tell me how long it's going to take you to stop that. When you exist in a culture that reinforces you to do the thing you've always done, and that's very often, that's how I look at, once people decide to, take the bariatric journey, whether they realize or fully realize it or not, they're signing up for that life of self-care, right? And, like I said earlier, that may be very counterintuitive for them, but the way they have to eat, they're countering so much history and so many habits that they've practiced forever, and they still exist in the world, the environment in which they've always lived in. So the house is going to reinforce the old lifestyle, not necessarily the new lifestyle. And that's why it's so important. I'm always a big proponent of this, of people getting plugged into the weight loss surgery community, because it's just such a unique space. And I think when people are plugged into that community, they get the reinforcement, to do the things they need to be doing for themselves. Otherwise, it's a tough thing because they're going to feel like they're alone. They're going to feel like they're the minority among their family, among their friends, culture as a whole, all that. And so it's so important to be plugged into that to get the support that they need.
Yeah, I know. It struck me when Rob Sivas, who's a bariatric surgeon, said that, basically when he does surgery, he said, I'm killing your best friend today. Right. So now you're going to have to find another coping mechanism. And if that's your way of coping with life, and he talked about it was an eye-opening for me. That was back on episode 11, I think, of this podcast, where he was talking about, all these other addictions coming up after the surgery, depression going up, suicide rate going up, alcohol, drugs, pornography, cheating on your spouse, all these things go up afterwards. And especially because it's surprising, but a lot of people I've talked to who've had surgery, that's analysis before surgery, but after surgery, they were just kind of on their own. They were left out to fend for themselves and figure it out.
Yeah. And that's unfortunate, the people that, are on that journey alone, when they don't have to. And, the great thing, and Dr. Trobe mentioned this earlier, the great thing about like the conference that we're a part of, you get to see that community in action, and I think you'll back me up on this. It's just such it's inspiring, it's encouraging, it's just such a great dynamic to be a part of, and the way they, uphold one another, encourage one another. I don't think I've seen anything like it, to be honest. It's that cool.
Brian, just so you know a little bit about this community, I met sort of some of the organizers, absolutely great. And I had asked them a very simple question. I said, how did you find me? And they said, we saw you fighting some bariatric surgeon, and we thought what you had to say was cool. And I was like, okay. And before they asked me to come talk, I was like, Brian, I told them, I was like, I just want to be clear, like, not that I'm against surgery. I'm not that I'm against medications. I'm not, we use these, but I try to keep people away from the knife as much as possible. You talked about Rob Sivas, the bariatric surgeon. I tell them all the time, we're trying to keep people away from you. And they didn't flinch one bit, Brian. They're like, come by and talk,
Yeah, those are good people, right? Because you want to have different views and say, hey, look, how do we all work together? Like, we can't be at war with each other. There's some people where it's an option. You go, look, you're kind of stuck, and this may be the option for you. So keeping an open mind on all of our parts and saying, how do we best? Of course, if we can avoid it, great. But sometimes, and I think that's the perception too, is in the weight loss community, a lot of people say, well, they cheated because they had bariatric surgery. It's like, well, there's a lot. I mean, that's not cheating. There's a lot of price you pay. And maybe you can talk about some of the downsides of what happens after surgery. That's a huge commitment and life change.
Yeah. Yeah, for sure. And, and what we've seen and what I've seen, for, well, my entire career, but especially in the last probably 8 or 10 years here, just the whole, regain after weight loss surgery. And so all these bariatric programs, and clinicians will develop these back on track programs and reset programs and all this, that, and the other. And then, well, and probably no surprise to you guys, I see a lot of people who are getting their second bariatric surgery now. So they had, for example, they had the gastric sleeve maybe 5 years ago, 3 years ago, whatever, and due to insufficient weight loss or anatomical stuff like GERD or whatever, now they have to get the gastric bypass. And with the regain thing, it's interesting because what I've found and what I've kind of tracked, the theme there is that, and the ASMBS came out with an interesting study, I think about 7 years ago, 2017, 2018. And in the study, the researchers identified the top 6 behaviors that patients who regain engage in. And what I've found and what I've tracked was pretty spot on with that. It's amazing how, and I said this earlier, how strong our habits and history are. And I don't think people fully appreciate that, because people will go back to the things that they've always done, especially when they don't have support. And one of the things that they identified in this particular study was just that lacking social support going forward. And again, that, just kind of testifies and lets us know how important it is to have that community. And what I've found from people, I was talking to someone else about this yesterday. We use this term a lot, where we're triggered to eat, we're all emotional eaters and all that. And there's certain things that trigger us. And what tends to happen with people, and what I've found too, when people don't address like the relational dynamics that are kind of wonky for them, that can serve as a big stressor and can serve as a big trigger. Well, now they're supposed to be practicing a certain lifestyle, but this factor, this stressor remains the same. And I, the people who, attend my classes and go to my groups and stuff, I always say this, remember, if nothing changes, nothing changes, right? So, how can we expect our behaviors to change if our thinking remains the same? And sadly, we all tend to gravitate to what's familiar, to us, even if it's dysfunctional, even if it's toxic. A lot of times we'll go back to things just because it's familiar. And the last thing any of us want to feel is to feel alone, to feel rejected. We don't want to be abandoned. And sometimes when people, are doing it on their own, they'll acquiesce rather than stick with the plan of like self-care that they established, just because they don't want sense or feel that.
Yeah, and you raise that point of family support. So we've seen the people who fail are the ones whose husband doesn't want them to be successful. They're insecure. They don't want their spouse to be attracted to other men and leave them, that kind of thing. And so when we see that, they're bringing home pizza and they're bringing home cake and they're paying money to lose weight. And they're like, wait a minute. Because, if someone has a weakness to cocaine or alcohol, you don't bring it home for them. You just go, oh, you have a weakness. Let's not do that. Right. But now that we have Thanksgiving coming up, a lot of people would never give their alcoholic family member a drink, but their obese family member or diabetic, they're gonna say, here, you have to have the pumpkin pie. Everyone's having it, and this peer pressure that comes when someone's trying to be successful.
For sure. Yeah, and people will change or fear that change in dynamic, relationally. And a lot of folks too, they think just because, and sadly, people think their value is tied into being needed, right? And so as long as I can do for you, Brian, like I have value in your life or whatever, when you no longer need me, to take care of you in certain senses or whatever, well, now I'm like, oh gosh, okay, so where's my value? Because now I can't do for you like I've always done. And so like I had no like value. And a lot of people fear that, they really, really do. We see that, quite often. That's a very common relational dynamic we've seen.
And
Yeah,
Dr. Steve, with your community, do you do like Zoom meetings with your community, that kind of thing, and build relationships?
Yeah. Well, I discussed a lot of topics over the course of the year, but yeah, I'm big on relational stuff, very big on that. And, sometimes like the question I'll ask people, with the regain thing is, okay, the typical clinician would ask them, okay, well, what foods are you eating again, that you used to eat and how did they come back in or whatever? And sometimes the question we need to ask people is, okay, well, who have you allowed back in your life that you kicked out, you set boundaries with, and now you don't have the boundaries that, you initially set with him. Again, going back to the whole trigger point that I was talking about earlier, um, and sometimes that's the case with people where, there's certain negative, certain toxic people they allow back in just for that whole fear factor of, being alone. And they'll allow them back into their lives. And then, those old relational dynamics get back in play or whatever. And, there's so much associated with our habits and what we do.
I cannot stress that enough. I think if you look at there was a New England Journal article, oh gosh, maybe like a decade ago, showing that how obesity spread through the Framingham data set. And it was just a 3D model connecting, basically, everybody in that data set and looking at the progression of obesity throughout time, throughout about 30 years or 35 years. And obesity spread in social networks, it spread like a virus, right? It literally went into these clusters, and those clusters basically expanded their sphere of influence. So, and then the clusters of people who did not have obesity, they also aggregated closer to each other and they shrunk in size in relation to this sort of expanding problem that we've seen over the past 5 decades. And it's truly a social contagion, right? Meaning that we either stress each other out and lead each other to food, or we trigger each other to eat the same food, or we come together and celebrate with, addictive food or obesogenic food. And I think that the social dynamics and these triggers, right, and how we manage these triggers with food, it's such an underappreciated aspect of this. We look at we look at obesity like a budgeting issue. We look at obesity like a willpower issue, and we don't stop to say, maybe this is a social sort of mind virus, maybe that's not the right word. It's a psychological phenomenon that
Yeah.
spreads to people around us.
Yeah.
So I'm curious to hear your thoughts.
Yeah, no, that's a great point. It's interesting how, we're so food centric in our culture. And one of the cool things I've been able to do over the years, like I've been able to interview people from, almost 3 dozen countries from around the world about, their health and weight struggles. And the data shows this too. So in the research, when people come here to the US, no matter their country of origin, they automatically like gain weight, and obviously, it's the processed foods, it's the access to food and all that. But, what we practice as a culture in regards to food, the way we talk about food, we will equate it to, like a relationship. We refer to it as a friend, from a marketing standpoint, I can't remember who it was. It was some hamburger, whether it was Burger King or Carl's Jr., whatever it was. They're showing the new burger that they came out, the new version of the burger, and they're playing, Marvin Gaye's "Let's Get It On."
Mm-hmm.
like it's a romance, but
Mm-hmm.
people romance food. We practice that, like I said, the way we talk about it and all that. And that's continually reinforced to us time and time again, social media commercials and all that. I was explaining to another group last week about this thing, and especially in our culture, it's true. But, as it pertains to food, we learn to associate it with soothing, comfort, and reward. Every stage of development, from the time we have a crying infant, we put a bottle in its mouth. You have the fussy 9-month-old in the high chair. You put Cheerios or fish crackers on the tray to keep them occupied. My generation, I'm probably older than you guys. I was rewarded with candy in second grade for getting, 100% on my spelling test. My little league team wins the game. Where do they take us? Take us out for pizza, ice cream. So every stage of development, we learn to associate food with soothing, comfort, and reward. And that message has been reinforced to us literally thousands upon thousands of times in our lifetime. And it always will. Marketers.
Yeah. I was stunned by that. I'm glad you're mentioning that, because during the lockdowns, when people were really stressed out and they started gaining weight, a lot of them were saying, I just started eating my childhood cereal again, like, Honey Nut Cheerios or Captain Crunch with Crunch Berries, whatever it was, when they remember watching Saturday morning cartoons and life was good and they could do whatever they want. Then they go play sports afterwards, And it was amazing how many people went back to Eggo waffles and, Pop-Tarts and all that. One of Tro's good friends really pushes Pop-Tarts. Tro.
Don't get me started on Pop-Tarts. I think that this concept of everything in moderation is what you're alluding to, Brian, which is, that doesn't work. Like Dr. Steve, you came from the addiction world, and I think that's what makes you unique. You didn't come at this from a bariatric, psychology world, where they don't do food addiction. I haven't met one bariatric psychologist that actually administers the Yale food addiction scale, right? Maybe they do a binge eating scale, maybe they don't. I have not met, one bariatric psychologist who talks about the concept of food addiction, right? So I think, your approach, your ability to take from the addiction world you came from, I wonder how much of that seeps into sort of how you help your patients and the people that you're counseling. As Brian said, you can eat a Pop-Tart if you want. I think that's like the
Well, it's just the comfort. I was making the point of it. It's your comfort that you remember being comfortable in doing these things, getting, ice
I would
cream
eat a
after
box
baseball.
of those as a kid, by the way, for comfort. I don't know if it was comfort. It was like, hey, there's like a box of Pop-Tarts here, and then you open one, and then you open the next one, and then you open the next one. I think there's 6 in a box, and the whole box is done. And you're like, why am I still hungry? I mean, yeah, I guess I wanted comfort, but the food itself is addictive.
Well, and Pop-Tarts is a great one to pick on in that regard because, okay, and you just said it, even after 6, it didn't make you full. Why didn't it make you full? Because the satiation factor is very low, obviously. It's not animal protein, so it's not fully going to get in there. And plus, you get that endorphin pop in the brain. working with it
Mhm.
years, over the course of my career, and it's kind of interesting how I can predict a lot of times what people's go-to foods are for emotional eating, depending on the context and their history with it. But of all the years that I've been working with people about their disordered eating and emotional eating, what do people typically binge on for that stuff, right? It's gonna be the processed stuff. It's gonna be potato chips, right? It's gonna be, the cookies, type of thing. And so carbs and sugar, the way it works, whenever we eat carbs and sugar, we want more carbs and sugar. That's why, chips is always plural, right? It's not chip, it's chips, right? And Oreos, you eat one, you eat three, and then a row. That's just how it works, that's just how it goes. And I've jokingly said this in my career. The day someone walks into my office seeking my help for emotional eating because they binge on chicken breast, I'm done. I'm out of here. I've never seen it once, right? It's like, yeah, you guys have been great. I'll be down the road. I've never seen that. And why is that? Well, first of all, with that example, it's hard to binge on chicken breast, first of all, because we have to use our mandible to break it down. So the speed factor, that kind of ruins, that, you have to eat it slowly as far as that goes. And you guys know too, once you swallow it and, it's in our pouch, it registers like you actually feel that, chips, you don't feel that. And, I tell, the groups I speak with too, you put a potato chip on your tongue, what's going to happen to it? It's going to dissolve, right? It's going to melt.
Mhm.
You put a piece of chicken breast on your tongue, what's going to happen to it? Nothing. It'll be there for a
Yeah.
week. After a couple of weeks, there'll be flies and stuff with it. But, that just tells us something. There's a difference there.
Yeah, I had two questions that were just stuck in my brain. When you're analyzing someone to get clearance for bariatric surgery, what are the red flags where you say, I can't clear this person based on what pathology? I've
Yeah.
never figured that out.
Yeah. You want my standards? You want what I'm
What's the
supposed
standard and what's your standard? I'm just curious
to?
if you go, this is a huge red flag that we got to fix first.
Yeah, so there's all the rule outs. Obviously, any active, substance abuse that's a no-no.
Excluding food, right?
Right, exactly. Yeah,
Clearly.
that's a caveat, right? Yeah, and then as far as like psychiatric history, anything untreated in that regard, people who have a history with it, and what life circumstances where they've dropped off from that care. Like I get them plugged back in, or I make that recommendation, and depending on the area
Mhm.
where the patient's from, like I'll recommend who they can see and stuff. That tends to be a no-go. Obviously, suicidality we rule out, for that. Even self-harm, if they're active in that, that's a no-go. And then for me, because I ask people, okay, so in regards to your surgery, can you tell me some of the potential risk or complications? And if they're not invested, if they can't, rattle off even the general stuff or whatever, I'm like, you need to do your research because we're talking about
Mhm.
your life, your body, your lifestyle. You need to know this stuff. And then the post-op, lifestyle, if they're not familiar with that, if they don't know what that's going to look like for them, if they think that, they can still eat the same way, just less or whatever, sorry, no,
Mm.
so those are the major ones, the most common ones for me. That's when I do not clear people.
Yeah, I find it interesting because you said one of the main character traits is that they're caring for other people and not themselves. By definition, by the time they come to you, now they're like invested in themselves. They want to go through this and make themselves better,
You'd hope
right?
so. You'd hope
So
so.
maybe even a different population that actually is going for surgery or those who never even consider it too.
And even that, and still, I don't think probably the majority of people fully realize the commitment aspect of it. Because they're just thinking, like we've been talking about, they're just thinking, the food perspective, how that's going to change, but all the other stuff that, tends to be at play that I alluded to earlier, stuff or their own personal history that's never been addressed, that's got to be taken care of too. And people don't fully realize that.
Yeah, I think I wonder, how many people, I wonder if this has been ever published, how many people are actually rejected from bariatric surgery? How many
Mhm.
people do not get clearance?
Mhm.
I would not be surprised to see like an above 99% acceptance to surgery. And I think when you look at the data for food addiction, you know, it's so incredibly high. It's, Gearhart says somewhere around 20 to 30% of the adult population, may have food addiction. And in the obesity space, it's probably half, I'd imagine, but I don't know that there's any great studies on it. But I wonder how many people actually get rejected, because I'd imagine if the bariatric surgeon is sending you that referral,
Mhm.
right, and you come back with a rejection, that's a financial hit to him, right? So there may be this implicit sort of bias.
Mhm.
And a lot of times now the clinics uh, have a psychologist on staff.
Mhm.
You're independent, but so I'd be curious to see the rejection rates. I mean,
Yeah,
what have you seen? What are the rejection rates you think are out there?
I think you're right. Yeah, I think you're right. And I've seen everything over the years as far as, rationale for rejection too. I've seen, because someone was still drinking soda, and they just started their 6 month journey to get surgery, they'll nix them for that. And I'm like, well, I don't know, but yeah, you're probably
Oh,
right.
like gatekeeping because they
Yeah,
didn't do enough,
yeah,
or
yeah.
you've seen a lot. Do you see more of that than the alternative? Like, gatekeeping because there's underlying psychiatric issues not being met.
Yeah, for me yeah, the latter. Yeah, that's the biggest for me, and you just know, from who I am or whatever, that that's a big one for me. When I see that unaddressed stuff, well, and my thing is, and this is how I frame it to patients too. It's that you can't, just not right now. We want to get you to a point of preparedness or whatever, and then proceed forward.
Yeah.
And when you frame it that way for people, that lets them know that, hey, again, they're not alone in this. We want what's best for you. And our decision is based on that.
Yeah, one of the crazy things I saw early on, even before I knew about low carb, keto, lifestyle changes, metabolic health stuff, I had a patient, this young girl, 32 years old, sweet as can be, doesn't want bariatric surgery. She doesn't want surgery. She doesn't want surgery, morbidly obese, and she has back pain, and she has all the comorbidities and sleep apnea and all these things. And the only thing her insurance would approve was bariatric surgery consult. And she said she doesn't want bariatric. So I was trying to get into a nutritional counseling. So every Friday, that was my thing. I would just do referral, denied, referral, but no one ever told me why I was denied. So I just kept doing it every Friday. That was my thing because I wanted to help this girl. I felt bad for her and she didn't have the financial means. So finally, one of the head guys from the HMO calls me like, "Do you not get this? Like, we've denied this like 33 times." I'm like, "Yeah, I was waiting for you to call me to explain it. What's your logic for this
Right.
person who's going to cost your system tons of money?" And the answer they gave me was, "We don't do nutritional counseling because the people change their insurance all the time, so we're not going to see the benefit of that, of the long-term
Oh my
disaster that
God.
we prevent. So we're not doing it. But we'll pay for bariatric surgery." I was like,
Yeah. Interesting.
"Okay."
Wow. Yeah. Crazy. Oh my gosh.
So they say wait till
That's
she gets the diagnosis. Once she gets the diagnosis of diabetes, then she could get her surgery. She doesn't want surgery. We don't want her to get diabetes, right? So yeah, it's frustrating. It's very frustrating for her, and so yeah, it's hard. It's a hard thing how the system is crazy. I know one of the big HMOs, and you either do a liquid diet, bariatric surgery, or veganism. That's it. Those are your three choices. Which one do you want to do? Like, ones I don't want to do any of those. Like, you're stuck. You get diabetes.
Yeah, it's pretty limiting.
Yeah, I'm just curious, like how you handle, somebody who may not want bariatric surgery, and maybe you think that they would benefit from it, or maybe, somebody, is on a medication and you think that's not a great option for them. You know, I'm curious, like, how do you interact with, because there's a lot of incentives either way, right? Driving people, there's a lot of personal incentives to do a surgery or go on a drug, or maybe there's a lot of personal convictions behind people who maybe don't want to do those things. And, I just wonder, like, how you approach the patient that, I don't know, like your gut tells you maybe this isn't the right thing. You mentioned, when
Mhm.
we first started, that you're seeing a lot of people who had bariatric surgery and now getting a duodenal switch. I know the biggest surgery right now for lap bands is lap band removal.
Mhm.
I'm just curious, like when you see that patient who's about to get their second procedure, my heart would melt. Like you just went through this, and I don't know if I would be compelled to, maybe consider like what alternatives do we have? What stone have we not left unturned?
Yeah.
What's your personal feeling when you see that, when you see those patients who had bariatric surgery and they're back, now
Yeah.
their doc is recommending another one?
Yeah. So like, I'll ask them, obviously I'll ask them, so, why are you seeking revision surgery? What happened? And then what I also ask them, because I want them to take ownership, well, what are some of the things maybe you didn't do that you should have in retrospect? Or, if you do this, what are you going to do differently going forward? And again, I've heard the gamut of answers on that over the years where, people will just say, well, the sleeve didn't work for me. I hear that phrase a lot. It didn't work for me. I'm like, okay, well, and we always say this, or I have always said this in my, pre-surgery classes I teach, it's a tool and the tool works best when you work with it. It's not just going to do its thing on its own. It may do that in the beginning or whatever, but long term it's not. You gotta dance with this thing, And so, for those people who present as, again, self-invested, where they get it, and you see that with people, you can you get a sense for them that they understand, they get it now. And what I've heard over the years too from people, I've also seen a lot of people over the years where they'll see me and for one reason or another they'll drop out and then come back a couple of years later or 3 years later, and they will unsolicitedly tell me, they're like, what, when I saw you a couple of years ago, my head was just in a different place. Now, I'm at a point in my life that, this has changed or whatever. And, you can just tell like they get it at that point. And there's something to be said for that timing, and usually those people tend to do, very well post-op, but it's interesting how they have that perspective where they can look back and know how themselves have changed or their mindset changed from when they initially sought it out till they get it a couple of years later.
I just, my head is spinning right now. It's like thinking all sorts of things, um, if that patient, right, like they come back and they say it didn't work for me, right? And maybe they're putting the blame on the procedure, right? I just go back to that surgeon, like did the surgeon select the right patient and the right procedure? Right. If that person doesn't have agency, even at that moment, they're basically said, I don't have agency when they're saying the surgery didn't work for me. Right. And you're looking to get them to get some ownership and skin in the game and see where they missed it. But what about the surgeon?
Yeah.
I would bet if you tied surgical payments to 2-year to 5-year outcomes, right, we would have a very different system.
Absolutely.
If you tied the outcome of that patient between year 2 to year 5, right, to that initial surgical payment, I don't know what, like, or there's a penalty if your patient regains weight, you have to pay back half of what you did, or you have to pay for the surgery, the repeat surgery. Now we're aligning incentives. But, if that patient is coming back after the surgery and they're still not invested, or they don't see the part they play in it, right? Like that is a systematic failure of the surgeon, in my opinion.
Yeah, it's not only that, there's an incentive. If they fail the incentives, you make more money because you're repeating the surgery. You're doing more intervention. You get paid every time you do that. So it's a hard thing where there's not good follow-up. I've seen that with patients that the surgeon does the surgery, they see them in the hospital, they go home, never see them again. That's it. Done. It's amazing. Especially because people travel to Mexico or other countries, they go and get it done, then they're just on their own. They come back and good luck. It's amazing that we can do that.
Yeah. Well, and the other trend that we're seeing too, where Years ago when I did my doctoral research and dissertation, I actually did it with weight loss surgery patients who were between 1 and 2 years post-op. And I picked that population on purpose because what I was seeing was the regain thing. I call it a crossroads. Like I could kind of predict fairly well, at 18 months, where the person was if they had really, the lifestyle as their own, so on and so forth. They weren't in that deprivation mode or deprivation mind. Those are the ones who would go on to do very well and sustain their weight loss long term. Those who didn't, that's when the regain phase would start around 18 months or 24 months. Now, and this is what's scary, I've seen this last probably 5 years, the regain phase is happening much, much sooner. We'll see it around 11, 12 months now.
Wow.
Because it's a different person, right? So
Yeah.
it's a different person who's ending up there. The population has changed. Those
Yep.
are people who probably failed GLP-1s at this point. And I don't want to say failed, but were non-responders to GLP-1, which means whatever's driving them to eat is so much more powerful than what we had before, what we saw before. I'm not surprised to see that in the slightest.
Yeah.
In fact, I think it's going to get worse and worse. And I'm already seeing it. Brian, I'm sure you've seen it. We're seeing the people who are no longer responding to GLP-1s, right? Like they had some success and they're coming to me because like I'm on this drug and I'm gaining weight. What do I do? We saw the bariatric surgery day one. You could rewind 7 years and it was I did bariatric surgery and I regained the weight. I don't think enough clinicians realize the tsunami that's coming with these weight loss medications. The
Well, not only
inability to
that,
tolerate them and the weight regain that we're starting to see.
not only that, Tro, you'll know the quote better than me, but they were talking about 12-year-olds getting bariatric surgery and going on GLP-1s, and you look at the lifelong. Is it 12-year-olds? I want to make sure I get it right.
Yep. Yeah. Adolescent kids,
Adolescents. So we have no long-term data on that. So
Oh my
how do
God.
we make these broad sweeping recommendations with no long-term data? We don't have any data on
don't
these.
don't get Dr. Steve involved in the controversies that the American Academy of Pediatrics, I'm going to say it flat out. This is not Dr. Steve's opinion. It's mine. Okay. Is a very, questionable organization on multiple fronts. But particularly, and I wrote this we actually wrote a letter to the editor. They wouldn't publish it. So we published it in the Journal of Metabolic Health. Barry, you got me started, Brian, man. You got me started.
Sorry,
They
man.
recommend
You got me in
recommend
trouble before,
surgery.
so
This is what they say that I like, which is don't withhold. Don't withhold bariatric surgery unnecessarily. Don't withhold, medications unnecessarily. Don't withhold it. You can imagine a case of a 14-year-old kid who's 500 pounds, right? Struggling to walk, not enjoying life. Don't withhold it. I understand, right? But then they don't talk about any medical care that's involved. But for low carb diets, just telling that 14-year-old kid to lower their sugar and lower their carb intake, you need 20 lab tests and one imaging study to safely implement that. So there's a systemic problem, and it extends beyond the surgeons. It extends beyond the organizations. I think it's not only the incentives have been poorly aligned, because the only way you get to a recommendation like that is regulatory capture, is really having a capture organization. But I think, because it sounds compassionate at face value, like don't withhold medications. If you're going to do a diet, make sure you do it safely. It almost makes sense. But when you take a step back and you put your common sense hat on, we all see something is terribly wrong. And you don't need to see it. There's no other population I know than the bariatric surgery population that is more a victim that is ripe for being taken advantage of. People who struggle with weight their whole lives, they're ripe to be taken advantage of. And it is a very vulnerable population. And I don't think any of our medical organizations are doing enough justice to this group.
Wow.
Sorry, you got me on this.
Yeah, and the psychology is the most important. Like it's so important, and they all interact with each other. That's what's so hard, and that's why I'm intrigued by your observation. Actually, I really am, and I don't know if it's causal or resulting with skipping meals and obesity. So I don't know if you have obesity first, then you start skipping meals, or you start skipping meals first and then you get obese, right? See, the causality, that's what I'm intrigued by, because we see people, and what's intriguing in my practice, I see people who start cutting their carbohydrates, and they go, I don't really feel like I have to eat lunch. I feel pretty good, and I'll eat dinner. They're not white knuckling it through because they're getting more metabolically healthy. So I'm just looking at the long term, so we don't screw up people. I think it's really important that we discuss that and kind of say, is it a result of that? Like, for instance, when I have a 400-pound person who goes, I'm just going to eat salad, and then they end up going to McDonald's and getting Big Mac fries and a Coke because they're starving to death because their insulin is so high. So we're finding that we get their insulin down, and they go, I don't really plan on my meals for the next month, that kind of thing.
Mm-hmm. Yeah. No, yeah, it's interesting. And what we found too with those eating profiles, the typical patient who, skips breakfast and they won't eat till, noon or 1 the next day, but then it's on. They will
And then
eat
they eat like tons more at night. Yeah, yeah. And that's a disaster.
yeah, they're making up for lost time there, right? So they're
Yeah,
eating
yeah.
the same amount of calories as the person who starts eating at 7 a.m., throughout the day. It's just not as efficient.
Or they're
Um,
making more impulsive choices, right? So like their hunger is not met at a time where they're more vulnerable and more exposed. Like at 7 o'clock in your home, it's your environment. You can have eggs or whatever. And then you get to 3 o'clock when you're ravenously hungry and you're left with the donuts at the office break room, right?
yeah.
So I wonder if it's truly like an issue. I suspect it's more of a sort of priming the pump issue leading to
Mhm.
an impulsive decision,
Yeah.
right? More than you must eat breakfast. But I
Well,
wonder
it's
if it's
kind of like
metabolics or what,
and you see like with Weight Watch, like patients who've been on Weight Watcher, like, I have so many points. 8 at night, I didn't use all my points. Oh, good. I get to save all these points and habits. So you're eating all this stuff right before you go to bed, and that's not a good option if you're not eating reasonably when you are eating. Right. If you go back to your junk food and processed foods and all that, I totally get that concept because you're starving and you go crazy eating and you can't shut down that hunger.
Yeah, and none of us are immune to that. We've all done it. Whenever that blood sugar level drops, anything that's good to us. I always like to say, I'll eat this stack of papers on my desk, throw some salsa on it. I do not care. I will eat it. You
Yeah.
know, I put myself in that position. And one of the things that I don't know if Dr. Tro's heard me talk about this before, but like I'll encourage like our bariatric patients because so often, and I've heard this quote a million times too over the years, where food becomes an afterthought. They just got, busy throughout their day or whatever, and they didn't think about food. I'm like, okay, well, how do we change that dynamic? How do we change that approach? And so I'll tell our patients, be preemptive, stay ahead of your hunger, and you guys know from a satiation, fullness standpoint, protein really helps with that, and it's gonna, the blood sugar levels could be more stable versus, eating the carbs and stuff where we get on that whole cycle thing, and that tends to really, help people, with their stuff. And then just the whole skill set of being a planner. I'll tell my patients too that, whatever you eat tomorrow, make that decision today. So it doesn't become an afterthought. So you don't get too wrapped up in work or, hauling the kids around or whatever, where you forget about, giving your body some fuel and nutrients, make that decision today for tomorrow, in the spirit of being proactive and being preemptive. And what I like about that too, it puts them in the driver's seat. They're controlling that now versus, when it gets out of control and that blood sugar level drops.
I think coming back to that point of planning, and just to tell the listener, to this day, 10 years into weight loss, literally, it was 10 years ago today that I started on my journey to lose weight and haven't kept it off. Planning, it sounds hard. People think about meal prep and stuff like that. Sometimes it's as easy as front loading eating.
Mhm.
Like just admitting and saying I struggle at work, I'm going to eat before I go. Right? I struggle at when I go out to eat with my friends, I'm going to eat before I go. Right? Imagine your hungriest moment where you always struggle with your decisions,
Mhm.
just walking into it ridiculously full. right? With foods that sort of support your body in the way you need. So planning doesn't have to be like grueling in a kitchen at, 6 o'clock at night on a Sunday, meal prepping and freezing it. It could literally be saying, you know what? Before I go to these places where I struggle, I'm just going to eat satiating food, right?
Yeah.
So that I'm not relying on my impulse control when I've struggled with impulse control for a lifetime, right?
Yeah.
Why would I rely on impulse control if I don't have any,
Right.
right? Or I struggle with it,
Yeah.
right? And I have employed the eat before you go for 10 years. And it's the most fantastic, easiest way to plan, which is, what you said. Which I think it just, planning could be psychologically planning. I think when I know you know this, but when the listener's listening, they may think pragmatically planning, right? Which is let me make my meal and take it with me to work or something like that, or let me meal prep my whole day, which that works too. But hey, just like your plan could be, when I get really ridiculously hungry at work, I'm gonna go to McDonald's and get 6 quarter-pound hamburger patties for $10,
Yeah.
right? I don't know, but is that, when you're working with your patients, how do you, it's tough to make it easy for them. I'm sure you do, and I'm sure you do, but it's tough sometimes to just make it easy.
Yeah.
I think that's
Well,
that's the trick that
mm,
I'm sure you do it. I know you do it, having met you, but how do you, what are your tips like that, to sort of help them plan, you know? Sorry to put you on the spot, but what
no,
tips do you have? Like, what are your top tips for somebody in that bariatric, you know,
mhm.
community that's, how do I do? They come to you, they're like, Dr. Steve, how do I do this?
Right. Well, and I think, we have to recognize, and I think most people admit this, we're slaves to convenience. We are slaves to convenience rather. And so as it pertains to our environment, we need to have good stuff in our homes. That means, okay, we need to take an inventory of a refrigerator. What's in there? What are your options there? What shouldn't be in there? Same with your pantry, right? What are your options? It starts there, just to be prepared. And, that takes time, and obviously there's going to be different people in your household probably where you're not always responsible for what's in the pantry or what's in the refrigerator, but, you own your stuff and you own, what you put in there, and I think that's, the first step right there, making it as convenient as possible, for yourself. And then kind of what you were just saying too, Dr. Cho, as far as like psychologically, just thinking, preemptively about meals. And, and most patients would admit to me that they think about food, they just think about it differently historically. Once they get on the, the self-care train, that thinking changes, because now they're thinking, and one of my little Steveisms, I'll ask patients, what are you giving your body to work with? And just that question is just a different way to think about food, and historically, we usually don't think about food in those terms. What do you mean? What am I giving my body to work with? Well, what are you giving your body to work with? And once people understand that, that changes their choices. And what I've always encouraged people to do too, and I call this the self-neglect versus the self-care mode thing, is try that for even like 7 days, right? So prepare your refrigerator, prepare your pantry, and be proactive, be preemptive as far as that goes, and document how you feel, document how you function throughout the week. And I think most people, if not all, like when they're honest about that or whatever, there's a distinct difference in how they function, how they feel when they're in that mode. And why I think that's important is that, we will maintain what we value. And now if I value that habit that I started, it's much more likely to stick versus if I don't have any value assigned to that. Does that make sense?
Mhm. Yeah,
100%. Yeah.
and Dr. Steve, what advice would you give us to when we have that patient who comes in, they're doing great, then they fall off the wagon, they get into a fight with their spouse, then they go get a gallon of ice cream and eat it, then they feel like like they're worthless and they're not worthy and everything. How's our best way to get them back on track and talk them off the ledge?
Yeah, just failure, is fleeting. It's a feeling, first of all. It's not a finality. Failure is not, the book isn't finished yet. We're still writing the book. And anyone who has any term of being successful and living the way in which they live, I like to put it this way, experientially, nobody can take that away from you. Your body and brain have experienced that. Therefore, you can reference that time. You can reference that experience. Once again, you know what to do. Nobody can take that away from you. That you. So the whole beating, and people, beating themselves up and all that. But, if we're talking adults, I think most of us who are self-critical and have a habit of doing that, we've done enough, man. How much more do we have to beat ourselves up over at this point? How many times do I have to call myself a slur or a name in my head? How many, I've already done that, I mean, come on. But yeah, I would encourage them just to remind them that, the failure thing, that's not a finality, that it's an act, we can get over that act and we can, re-implement that we once had implemented.
Yeah, and I've seen that too. And some people in the last, okay, so that happened. What did you learn from that experience? What would you do different next time? And then they have this whole plan. I would have done this. Okay, good. Look, you learned. It's a learning experience. We're good.
Yeah, exactly. Yeah, and I'll tell them, look out the windshield, not the rearview mirror. Don't dwell on that stuff. We're going this direction. We're not going that.
Awesome advice.
Yeah. One of the things that I say, and you kind of hit it right now, is I've never seen anybody shame and guilt themselves and self-blame themselves to weight loss. I have not seen it. I've never seen it happen. I mean, maybe it happens in other places, but I've never seen it happen. And a lot of times I see it feeding the cycle of negative emotions, turning to food, and then coming right back to self-blame and shame and guilt. I can't agree with you enough. I got to be honest. Everything you're saying, I'm like sitting here nodding my head. Everything that Brian's saying, I'm sitting here nodding my head. I absolutely agree on every front.
Yeah. And one last thing that, you guys can, choose to use if you want going forward is that, the other common thing that we see with our folks, if it's true that, they tend to be people pleasers and they're great about taking care of everyone else. The other thing that's very common is that they tend to be very self-critical. And of all the relationships we have, when we get on that self-care, journey, there's a relationship with food. Obviously, that's going to change relationship with others, but probably the most important one is a relationship with yourself. And if you continue to practice being self-critical, the message that you're reinforcing to yourself is that you're not worth it. And if you're telling yourself you're not worth it, you're not going to sustain it, right? Because you have to matter. You take care of what matters, and we need to, understand and accept that, hey, you're worth taking care of, you matter. You're worth the time, energy, and every effort, to do that very thing.
Yeah, I think having the ongoing support from you and having someone in their corner. So a lot of people don't have anyone in their corner. So having someone who believes in them or that they're accountable to, even, it's a huge thing. And for us, Troy, I know Troy does also. We have group meetings where we can get all of our patients at once. And it's always that person who goes, you know what, I didn't want to come tonight because I've been blowing it. And everyone in that group is supportive and kind and speaks truth to them and helps encourage them, because they have all this negative self-talk going on. And when they realize, oh, I'm not the only one struggling, everyone else has to go through these things. When you can't have your favorite dessert, everyone's like, yeah, I skipped it last night too. Right. So, and I sucked 2 weeks ago, but something you said helped me get back on track. Let's do this. And, just have that team and that encouragement that, I mean, so many people just don't have that in their life. And it's really tragic.
Yeah, unfortunately. Yeah. For sure. Yeah, that's a difference maker for certain.
True. Yeah, I'm waiting for you to ask me another question, man.
No, I was going to say this is all awesome. I'm
Yeah, it's
soaking it all
great.
in, and I know I'm going to have like 15 different. What we have to do? We got to get you on our Toward Health app and get you on our groups. We have a group. They'd love to hear from you. But how do people track you down if they're listening to this and they're like, gosh, I want to work with Dr. Steve? How do they track you down? How do they find you? How do they get your insight and input?
Sure. They can visit my website. It's just Dr. Stephen Reyes, REYES.com. That's our main website. They can also get a free copy of the intro to my book that's coming out. They can download that for free to check that out and kind of see where we're going with that. But
What's the book called so people can watch out for it?
Yeah, we got to put it on their list.
yeah, you guys will kind of be familiar with this concept. So I call it the bariatric code. Yeah. So
All right.
your self-care guide for lifelong success. But yeah, it's called the bariatric code. And
Love
so
it.
it's a philosophy, it's a paradigm that people can turn to time and time again. But obviously there's some tips in there, but there's a lot of, because who I am as a researcher, there's a lot of phenomenological, a lot of, life experience stuff in there as far as, interviews I've had with patients over the years and some of their quotes and just some of the lessons I've learned from them over the years to impart that experience, impart that wisdom to other people. Yeah, we're pretty excited about it.
All right. And
Awesome.
where are you taking patients from? Can they be from California, other states, or how does that work?
Yeah, anywhere. So, like the coaching stuff, and so we're actually starting our own group too. It's called the Self-Care Society, that people can become members of, join that, and they get to spend some time with me as I facilitate, different topics and different, teaching things. So, yeah. Oh, and our Instagram too. On there, it's Dr. Dr. Period. Again, Stephen Reyes. That's my main social media is my Instagram. I don't have Facebook anymore.
Me either. Yeah.
Yeah. I got them all. Listen, thank you so much for joining us. Yeah. Thanks for, I've been thinking about leaving some, but so far I have them all.
Okay.
But we'll put that all in the show notes. We'll put the community and your social handles. And thank you for taking time out and joining us. I know people are going to hear this and they're going to be moved and passionate and hopefully if somebody needs help out there who's listening to this, they'll reach out to you.
Awesome. Cool. Thanks for having me, you guys. I appreciate it. Great conversation.
Yeah. Thanks, Dr. Steve. Appreciate you coming and really enjoyed our time.
Appreciate it.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.